Hello student, now we are going to discuss another topic, that is countercurrent system in kidney. So what does this term countercurrent system means to you? Okay, so countercurrent system means four criteria should be fulfilled. What are those criteria? Number one, there should be presence of two parallel tubes. Okay, so two parallel tubes should be present. So in your diagram you can find out this is one tube and this is another tube. Now, second criteria is that opposite direction of fluid movement in this tube. If the fluid is flowing in downward direction in this tube, then the nearby tube should have a flow in the upward direction. The flow should be opposite in both the tube. Then the third one is that these tubes should be present in very close proximity to one another. Okay, if they are very long away from one another, then countercurrent system is not going to operate. So they should be very close to one another. And number four criteria is selective permeability of this tube. What is the meaning of this? Meaning of this, if the first tube is permeable for only water, then the second tube has to be impermeable for this water transport. If the first tube is impermeable for solute, the second tube has to be permeable for solute reabsorption. Getting my point? So this way you have to fulfill four criteria, and then only the countercurrent system can operate. With these four criteria, if you look at, it is not the kidney where the countercurrent system operate. Intestinal villi, okay, they also contain countercurrent system, the exchange of oxygen there. At the level of skin, okay, at the level of testes, the pampaniform plexus, they also have countercurrent system apart from this kidney. So in today's topic, we are going to discuss the countercurrent system of kidney. Okay, so first of all, the general understanding. Okay, countercurrent system, the mechanism of countercurrent system. First, you try to understand like this. What is the aim of this mechanism? Why countercurrent system is there in your kidney? What is the aim? What is the target? So the main target or the main aim of this countercurrent mechanism is to develop and maintain a hypertonic medulla. That's what I'm saying. So main aim of this system is hypertonicity, to generate and maintain hypertonicity of medulla. Why? If you generate hypertonicity of medulla, what will happen? Why this is the aim? If by any means, if you convert your medulla into hypertonic, it will leads to reabsorption of water by the process of osmosis. So if you reabsorb more and more water, what will happen? The ultimate thing is that urine concentration is going to happen. Okay, so urine concentration is going to happen. That's why we say the main aim of the countercurrent system is urinary concentration. Now this mechanism is working in which type of nephron? We know cortical nephron is there and juxtamedullary nephron is there. The juxtamedullary nephron contain long loop of Henle and long loop of peritubular capillary. That long loop of Henle and long peritubular capillary is responsible for this countercurrent mechanism. So that's why you have to remember that this is the mechanism which is working in juxtamedullary type of nephron. So this mechanism has two parts. One is countercurrent multiplier. Okay, I'll tell you what is the meaning. And second one is countercurrent exchanger. Okay, countercurrent exchanger, right? So the countercurrent multiplier, this system is responsible for generation of the medullary tonicity. I told you the mechanism is going to produce a hypertonic medulla. Medullary interstitium will be hypertonic. Who is going to generate that hypertonicity? That is the multiplier. And after generation, who is going to maintain that hypertonicity? That is by countercurrent exchanger. So I'm writing here the countercurrent multiplier is for generation of medullary hypertonicity, medullary hypertonicity. And this exchanger, this is for maintenance of medullary hypertonicity. Great. Medullary hypertonicity. Getting my point? So now question is, which part of the nephron is responsible for counter current multiplier? So the counter current multiplier, as we know, that the main part of the nephron which is doing this job is loop of Henle of juxtamedullary nephron. The long loop of Henle in the juxtamedullary nephron, they are the main part. Now if I ask you, loop of Henle means there is a descending part, there is an ascending part. What is the main segment of the loop of Henle? The main segment of the loop of Henle which is responsible for counter current multiplier is TAL, thick ascending limb of loop of Henle. This is the main segment of the loop of Henle which is responsible. And loop of Henle also has ascending thin segment. This is the very less important segment, but it is also responsible for counter current multiplier. But also remember that apart from loop of Henle, the collecting duct, particularly the medullary collecting duct, is also component of counter current multiplier. I'll explain why I'm putting the medullary collecting duct also. So loop of Henle is there and medullary collecting duct. Okay, these are the two segments which will generate the hypertonicity of medulla. And after generation, some part of this juxtamedullary nephron, okay, or the peritubular capillary, they are going to maintain that. They will prevent the washout of this hypertonicity, and that is done by vasa recta. So that's why we know that counter current exchanger is done by vasa recta. What is vasa recta? We all know vasa recta is nothing but long peritubular capillary loop surrounding the juxtamedullary nephron. So the vasa recta is counter current exchanger. Okay, multiplier. It is not multiplier. Okay, it is exchanger. Multiplier is loop of Henle and medullary collecting duct. Now we have to understand how this mechanism is happening, right? So to understand this mechanism, I have already made one diagram here. Okay, I have already made one diagram here. What is the diagram? Very easy diagram, as you can find out here, that this is the part of the descending limb of loop of Henle, this is the ascending limb of loop of Henle, that is the ATS and TL, and then this is the DCT, and then this is the collecting duct. I have not made the proximal convoluted tube, I have not made the Bowman's capsule. Okay, so this is the diagram. Okay, now this diagram, obviously this is a diagram of the juxtamedullary nephron. Upper part, okay, that is above this broken line, this is the part of the cortex, and below this is the medullary part. So as you can find out here, the loop of Henle, that is a long one, and that is mainly present at which part of the kidney? Medullary region of the kidney, medullary region of the kidney, right? So the first thing that you have to understand here, why this is counter current system? So there are parallel tubes. The two loop of Henle, they are parallel to one another. So this is parallel to one another, and this medullary collecting duct, this is also parallel to other one. The flow of urine in downward direction here, the flow of urine is upward direction here, flow of urine in downward direction here. So all these three parallel tube, okay, loop of Henle descending, loop of Henle ascending, and the medullary collecting duct, they are parallel to one another. Then they are very close to one another, and the flow of urine is opposite to one another. So that's why they are forming a very beautiful counter current system. Now how this counter current system, okay, will generate the medullary tonicity, means we are describing the multiplier system, how it is going to generate the medullary hypertonicity. Okay, so the filtration which is occurring at the level of glomerulus, I told you already that this filtration is isotonic in nature. Isotonic means the osmolality of that filter will be 285 to 290, but for our understanding purpose, for easiness, we are taking that isotonic means the osmolality is 300 millimole per liter. So even at the level of proximal tubule, we know that the absorption is isotonic in nature. So the proximal tubule urine tonicity is also 300 milliosmol per liter. So the urine which is reaching from proximal tubule at the level of this descending thin segment, it will have a tonicity of 300 milliosmol per liter. Okay, but the proximal tubule and glomerulus, they are located at the level of this cortex. So what will be the tonicity of the cortex here? This is also 300. Okay, so this just corticomedullary junction, it will also have a tonicity of 300 milliosmol per liter. Okay, that's why this is isotonic, right? Okay, now when this urine is passing through this descending thin of loop of Henle and it is reaching at the level of TAL, the first important thing is going to happen here. Okay, so just imagine that countercurrent system has not developed yet in this diagram. It has not developed yet. We are going to generate that. How it is going to be generated? So suppose the first time the filtration has occurred and first time the isotonic solution is flowing through the loop of Henle. First time. So what is going to happen? So whenever this isotonic solution is passing through the TAL, so I hope all of you know that this is the TL. What is going to happen? The TAL is going to absorb, okay, sodium and chloride along with potassium. The transporter is NKCC. I hope you remember. But after reabsorption, I told you the potassium is diffused back into the lumen. So ultimately, TAL is absorbing which molecule? Sodium as well as chloride. I am not writing potassium. Why? Potassium will diffuse back into the lumen. So please don't confuse. That's why I am not writing potassium. So sodium and chloride will be reabsorbed by the TAL. So sodium and chloride is reabsorbed by TL. So there will be reabsorption of more sodium, more chloride, more sodium, more chloride. It will enter from lumen to the medullary interstitium. Getting my point? Similarly, if you think of the segment of the ATS, ascending thin segment of the loop of Henle, I told you this is the segment which reabsorbs sodium and chloride by paracellular pathway, passive pathway. But anyway, it is also reabsorbing sodium as well as reabsorbing chloride. So whenever this isotonic solution for the first time flowing through the TAL and ATS, it is reabsorbing sodium and chloride, and that is placed at the level of medulla of the kidney. So sodium and chloride is there at the level of medullary interstitium. Okay, now after that, when the urine is further flowing and going through the level of medullary collecting duct, not the cortical collecting duct, medullary collecting duct, at the level of medullary collecting duct, there will be reabsorption of urea also. Please note down, medullary collecting duct can reabsorb urea but not the cortical collecting duct, and this urea reabsorption is under the influence of ADH. ADH stimulates this urea reabsorption. So this is an MCQ. ADH, not only water, it also enhances urea reabsorption in which segment of nephron? Medullary collecting duct. Cortical collecting duct cannot. So now I can understand, due to reabsorption of sodium and chloride from TAL and ATS, the medullary interstitium is already having sodium and chloride in huge amount. Apart from that, the urea is also reabsorbed from medullary collecting duct, means inner portion of the medulla. So due to presence of these three, that is sodium, chloride and this urea, what will happen to the tonicity of the medulla? The tonicity will rise more and more. Getting my point? Sodium, chloride, urea, all of them, they will rise the medullary tonicity. So if your cortical tonicity is 300 milliosmol per liter, I told you the corticomedullary junction will also have a tonicity of 300. But if you enter more and more deep inside the medulla, there will be increase in more and more tonicity. And why this tonicity is increasing more and more towards the inner part of the medulla? Because in the upper part there is only and only sodium and chloride, but if you enter in the medullary collecting duct region, you are getting urea along with sodium and chloride. That's why this hypertonicity will not be homogeneous in every part of the medulla. If you go from cortex towards the medulla, the tonicity will rise gradually, like for example 300, then 500, then 800, then 1000, then 1200, then 1400. This way the tonicity will increase gradually from cortex towards the medulla. Okay, and this increment is due to sodium, chloride and urea. Urea is only present at the inner part of the medulla. So basically I am understanding that because of the absorption of this sodium, chloride and urea, medulla is becoming hypertonic. Okay, hypertonic medulla. Okay, so that hypertonic medulla is not homogeneous. From cortex towards medulla, there is a gradation of this tonicity. This gradation of the tonicity is known as corticomedullary osmotic gradient. Corticomedullary, okay, osmotic gradient. Generation of this corticomedullary osmotic gradient is done by countercurrent multiplier system. Getting my point? So what I'm saying, the countercurrent multiplier system I told you, that is for generation of the hypertonicity of the medulla. Hypertonicity of the medulla is not homogeneous. There is a gradient from cortex towards the medulla. Okay, this corticomedullary osmotic gradient is generated by countercurrent multiplier system, where TAL is taking part, that is the main segment, ATS ascending thin segment is also taking part, and urea, which is reabsorbed from medullary collecting nerve, that is also taking part. Now question is, if there is generation of this hypertonicity, what will happen? Why this is required? I told you this is required for reabsorption of water. Why? Because after this tonicity is generated, after this hypertonicity is generated, what will happen? Whenever the isotonic solution will flow through this segment. Which segment I'm talking about? I'm talking about this descending thin segment of Lubbofen layer, which is impermeable to solute, but it can reabsorb water. So now, suppose the hypertonicity of the medulla has been generated already, okay, by countercurrent multiplier system, and now the isotonic solution, that is a 300 milliosmol urine, is passing through this descending thin segment. So what will happen? Inside is 300, outside is 500. Inside is 300, outside is 800. There will be osmosis. What is osmosis? Water, that is a solvent, moves from low solute concentration, that is 300, to high solute concentration. So now this water will be reabsorbed from this tubular lumen to the level of medullary interstitium. Okay, water will be reabsorbed from this tubular lumen towards the medullary interstitium by the process of osmosis. Now question is, how long this water reabsorption will continue? This water reabsorption will continue until and unless the inside urine tonicity becomes same with that of the outside tonicity. Getting my point? So absorption of water is going on by the process of osmosis. Low solute to high solute water is going. How long this water will continue to be reabsorbed? Until and unless the inside tonicity becomes same with that of the outside tonicity. Means if it is become 500, then water reabsorption will stop. If it is become 800, the water reabsorption will stop. If it is become 1000, then it will stop. And if it is become 1200, then only the water reabsorption will drop. So now I can understand, because of this corticomedullary osmotic gradient, water reabsorption at the level of this descending thin segment is going on, and because of that, what is happening? The urine is becoming hypertonic at the level of tip of Lubbofen layer. That's why I told you that corticomedullary osmotic gradient, that is nothing but medullary hypertonicity, is generated by countercurrent multiplier system, and because of the generation of this multiplier hypertonicity, the water reabsorption is occurring from DTS and urine getting concentrated. So now I am asking you that this urea reabsorption, okay, so before that, the urea reabsorption, you have to remember certain point. The urea reabsorption from medullary collecting duct is done by certain transporter. Remember that from luminal surface, the urea is absorbed by a transporter which is known as UTA1, and from the basolateral aspect the UTA3, right? So basically we are discussing the urea transporter. This is important for MCQ. Urea transporter, right? UTA, UTB, A and B, two main types of urea transporter. UTB, it is present at the level of RBC membrane, okay, and UTA, it is present at the level of kidney. Now this UTA, it has three subvariety: UTA1, UTA3, and UT, obviously A2, 1, 2, 3. One is present on the apical membrane of medullary collecting duct. 3 is present on basolateral membrane of medullary collecting duct, and 2 is present in descending thin segment of loop of Henle. Getting my point? So this urea, which is reabsorbed here, some of the urea may enter into this descending thin segment of the loop of Henle. Some of the urea may enter here, and if I ask you what is the name of the transporter through which the urea is entering the descending thin segment of the loop of Henle, the UTA2, right? And UTA1 and 3, UTA1 and 3 is located in the medullary collecting duct. And this transporter UTA1 and 3, they are stimulated by ADH. That's why ADH enhances urea reabsorption, right? So in the process of multiplication, we have seen sodium chloride is also there and your urea is also there. If I ask you, tell me how much contributed, how much tonicity is contributed by sodium chloride and how much tonicity is contributed by urea. Okay, so Guyton is saying that 50 to 60% contribution is by NaCl and 40 to 50% contribution by urea, right? So sodium chloride is contributing 50 to 60% and medulla is become hypertonic. So what is the maximum tonicity that can develop? I have written here this number, although these numbers are arbitrary, but I have written this number up to 1400. Generally this is 1200 to 1400. Different books are saying different value, but the maximum tonicity that can be generated at the level of medulla is 1200 to 1400. So if we assume that the medullary tonicity is 1200 milliosmol per liter, then I can understand that 50% of this milliosmol is due to NaCl, approximately 600 milliosmoles is due to sodium chloride, and another 50%, that is urea, is 600 milliosmol. That's why the total is 1200 milliosmol. I am taking that both of them are equally contributing, although sodium chloride is a little bit higher. Okay, fine. Now, sodium chloride is contributing 600 milliosmoles for medullary hypertonicity. How much is contributed by sodium alone and chloride alone, right? Sodium and chloride, they will be divided. So sodium alone, obviously it will be half and half. So sodium alone will contribute 300 milliosmoles and chloride alone will contribute 300 milliosmoles, and urea is already contributing 600 milliosmol. So if I ask you the single most important substances, okay, so the single most important substances for medullary hypertonicity, what will be your answer? Urea. Okay, urea. So please note down, if the question is like that, the single most important substances for medullary hypertonicity, your answer is urea. But suppose you are getting a question that which of the following is the most important for medullary hypertonicity, your options are like this: A, NaCl, and B, urea. Now which one is more important? I told you NaCl contribute 50 to 60%. So this is your answer. But if IMCQ is giving same but options is given like this: A option is sodium only, B option is chloride only, and C option is urea only. So what is the most important among all these three? Now your answer is urea alone. Getting my point? So this way, please remember, medullary hypertonicity is generated by three substances: sodium, chloride, urea. Single most important is urea, which is reabsorbed from medullary collecting duct. So this way you are generating medullary hypertonicity, and because of the generation of the medullary hypertonicity, what is happening? Water reabsorption is occurring in the descending thin segment and urine is getting concentrated. Now we will see this mechanism once again in a step-by-step fashion. Okay, so please look at. So the same countercurrent multiplier we are trying to understand once again in a step-by-step fashion, right? So first here, okay, so you can find out here, this is the descending thin segment, right? And this is the TAL, okay, this is descending thin segment, and this is the medullary interstitium. So for the first time, when the isotonic solution is flowing through here, what is the tonicity of that? 300. So everywhere it is 300. So for the first time, everywhere 300. And how much will be the tonicity in the interstitium? That is also 300. Now what next? Next is that the first important step in countercurrent multiplier is reabsorption of sodium and chloride and potassium, but potassium will diffuse back into the lumen. So sodium and chloride reabsorption from TAL, that we are going to show you here. So sodium and chloride reabsorption is going on. Sodium chloride reabsorption is going on. So whenever sodium chloride reabsorption is going on from this TAL segment, look at this number, this 300 number, you are reabsorbing sodium and chloride from this 300. So what will happen to the tonicity of the luminal content? It will decrease. And what will happen whenever you are adding sodium and chloride in this medullary interstitium? It will rise from 300 to more, right? So that way, look at this number. The tonicity in the lumen is decreasing because you are absorbing sodium and chloride, and the tonicity at the medullary interstitium is rising from 300 to 400. That is the first step, and that is the most important step. That is the primary steps of countercurrent multiplier. Now what is next? Next is, suppose this is still in 300. Okay, suppose this is still in 300. So in the next step, what is going to happen? There will be absorption of water by the process of osmosis. So look at here, water is reabsorbed from the descending thin segment of the loop of Henle by the process of osmosis. So whenever you are reabsorbing water, there will be little decrease in tonicity of the interstitium, and there will be little increase in tonicity of the lumen of the nephron, right? Luminal content of the nephron. But ultimately, this water reabsorption will continue until and unless there is a balance between this descending thin segment of loop of Henle and medullary interstitium osmolality. So how long this water reabsorption will continue? Because of the water reabsorption, what will happen? The tonicity of the lumen will be same with that of the tonicity of the interstitium, right? So whenever you are reabsorbing water, interstitial tonicity decreasing, luminal tonicity increasing. So there will be a balance. This will continue until there will be balance. So now the tonicity of the interstitium is balancing that of the descending thin segment. So this is the first cycle. This is the first cycle. So at the end of first cycle, I can understand that the medullary interstitial tonicity has already increased to 400, and urine is also concentrated a little bit to 400. Now what is next? Now the second cycle will begin. In the second cycle, the same thing will happen. Okay. In the second cycle, fresh solution is reaching here. So just understand that fresh solution is reaching here. So fresh solution means what is the tonicity of that? 300. So the fresh solution is reaching from proximal convoluted tubule to the descending thin segment. That fresh solution, which has a tonicity of 300, it will push this 400 solution which is already there. Push. So whenever it is pushing, this 400 will move to the opposite side, that is the TL region. So now look at this number. So this 300 means fresh solution from the PCT is reaching here. It has pushed the 400 which was already there. So this 400 is now reaching at the level of TAL because of the pushing from the descending thin segment. Now again, the TAL will do the same thing in the second cycle. What is the same thing? Absorption of sodium and chloride. So now the TAL will reabsorb sodium chloride once again. Okay, so now it is reabsorbing sodium and chloride. Now it is reabsorbing sodium chloride, and that sodium chloride is delivering at which level? In the interstitium. The interstitium is already in 400. So if you deliver more sodium chloride into the 400 interstitial, so interstitial tonicity will rise further, right? So that way, look at the number in the next. Because of the absorption of this sodium and chloride, the interstitial tonicity is rising further, 500. Okay, so 400 to now it is 500. So you can find out that there is a difference between this TAL luminal tonicity and medullary interstitial tonicity, but this difference will never go beyond 200. It cannot be more than 200. Means it cannot be here it is 100 and it is here 500. Okay, it cannot. It generally does not go beyond 200. Okay, so this is 300, this is 500, that is okay. But if it is 150, then it should not be more than 350. It should not be more than 350 like this. So this way, remember that the difference between these two limbs should not go beyond 200, right? But anyway, whenever you are adding sodium and chloride into the interstitium, the interstitial tonicity is rising further to 500. And in the descending limb, what is the tonicity? Tonicity is 300, 400 like this, and interstitial tonicity is 500. Do you think this equilibrium will be maintained? Answer is no. Again, there will be reabsorption of water from descending thin segment. Okay, because descending thin segment is permeable to water, but TAL is impermeable to water. So what will happen? Now the water reabsorption will continue. Okay, so whenever the water reabsorption is continued from this DTS, descending thin segment of loop of Henle, to the interstitium, the tonicity of the DTS will rise until and unless there is an equilibrium with interstitium of the medulla, and that way the tonicity is becoming 500, 500, 500, 500. Getting my point? So whenever there is a rise of tonicity of the interstitium, the descending thin segment urine is also rising in tonicity to match it. That way, more you absorb sodium chloride from here, the tonicity in the interstitium is rising, and that is helping in water reabsorption from this segment. And that way, your urine is becoming hypertonic at the level of tip of loop of Henle. So this generation of the hypertonicity at the level of medullary interstitium is done by counter current multiplier system. But we have seen here that number is 500, but I told you how much is the maximum number, 1200 to 1400. So how this will happen? This cycle that I have described, this will continue multiple times again and again. And Guyton is saying this cycle will repeat at least 4 to 6 times, and after 4 to 6 times, the final tonicity that is going to reach here is 1200, 1200, 1200. That's why I am saying that medullary hypertonicity maximum can reach up to 1200 to 1400, and urine tonicity at the level of tip of loop of Henle will be hypertonic. And how much that will be? That will be equal to the medullary tonicity, that is 1200 to 1400 millions mole per liter. So this way, counter current system is operating. Counter current multiplier. What about counter current exchanger? What I told, what is exchanger? Exchanger is there to maintain the tonicity. And what is exchanger? The vasa recta. Where the vasa recta is there? The vasa recta is a capillary loop which is present surrounding this loop of Henle. So whenever you are reabsorbing sodium or chloride, okay, so you are reabsorbing sodium and chloride and urea at the level of medullary interstitium. If I ask you, what is the ultimate fate of this sodium and chloride and urea which you have reabsorbed in the interstitium? It will not remain in the interstitium. Ultimately, from the interstitium, it will be reabsorbed in the blood, capillary blood. What capillary blood? Vasa recta, that is the capillary blood. So look at. So this solute that you have reabsorbed from the TL and ATS, that is the sodium, that is the chloride, that is the urea, ultimately this solute will be reabsorbed into the capillary blood, that is the vasa recta blood. So whenever this solute is entering in the capillary blood, the tonicity is rising at the level of vasa recta also. But if the blood is taking out all this solute like sodium, chloride, urea which you have reabsorbed, suppose this blood is taking out all of this from the medulla and it is draining all of this solute at the level of renal vein, what will happen? You are reabsorbing all of this, You are taking all of this solute from interstitium and then you are bringing all of this solution and draining into the renal vein blood, into the systemic circulation. So what will happen? The solute concentrated in the medullary interstitium will decrease to a very low level, but that is not acceptable. So that way, the vasa recta has to, okay, again reabsorb this solute from the ascending limb of vasa recta. So whatever solute is entering at the level of the descending limb, most of the solute will be reabsorbed at the level of ascending limb of the vasa recta, sodium chloride, urea, and very little amount of solute will be excreted at the level of renal vein. That means vasa recta is not washing out all of the solute from interstitium. It is keeping those solute in the interstitium. It has to absorb, but after absorption again it is reabsorbing from the ascending limb. So that way it is keeping the solute in the level of medullary interstitium. So this is known as maintenance of tonicity. This is known as maintenance of medullary hypertonicity, and that is done by vasa recta. Okay, descending limb is taking the solute and ascending limb is again bringing those solute into the interstitium, and water is moving in the opposite direction. When solute is entering in the vasa recta, water is going out, and when solute is going out, the water is entering in the vasa recta. So this way, this loop of vasa recta is maintaining the medullary hypertonicity. So rather than there is a loop, if the vasa recta become a straight tubules, okay, vasa recta is a straight tubule. What will happen? So whatever solute will be reabsorbed here, can you reabsorb those solute again in the interstitium? No, it is entering here and it will pass to the renal vein directly. Getting my point? So that way, if vasa recta becomes a straight tubule, then maintenance of the medullary tonicity will not be there. What will happen? There will be wash out of medullary tonicity. If the medullary tonicity is washed out, means medullary tonicity become reduced, what will happen to the urine tonicity? Urine will be hypotonic. So that's why please note down that if the question is like that theoretical question, okay, that if the vasa recta, rather than forming a hairpin shaped loop, if it has become a straight tubule, what will happen? Your urine will be hypotonic, because that straight tubule means your medullary tonicity will be washed out. Same way, if the blood flow or if the blood flow velocity or blood flow volume, if they are increased at the level of vasa recta, the same thing will happen. Why? Because this entry of solute in the descending limb of vasa recta and reabsorption of solute from the ascending limb of vasa recta, it takes some time. It is a time consuming process, entering and then reabsorbing. You have to give some time so that you can reabsorb from this ascending limb. But if the blood flow at the level of vasa recta increases to a very high level, the medullary blood flow is very low, and that is helpful here, because this slow blood flow, this sluggish blood flow is helpful for the reabsorption of this solute. But if the blood flow become huge, if the blood flow velocity is high, then again there will be wash out of medullary tonicity, and whenever there is washing out of medullary tonicity, the urine will be hypotonic. So this way you have to remember these two things, that if the vasa recta is straight or if the blood flow in the vasa recta is become very high, then there will be wash out of the medullary tonicity, and that will lead to hypotonic urine. So this is all about your counter current system, the multiplier and the exchanger. So now if you look at certain MCQ, okay, this will finish this topic. Normal range of urine osmolality. I told you, if the medullary interstitium is hypertonic, urine will also be hypertonic. And what is the maximum medullary tonicity can be generated? That is 1200 to 1400 milliosmol per liter. So that way, the maximum urine tonicity can also reach up to this level, and the minimum urine tonicity that can go up to 30 to 40 milliosmol per kg. So this way, the best answer possible here is A, 50 to 1400 milliosmol per liter. Because if you look at the other option, 1200 is there, but 300 is not the minimum one. Minimum one can reach up to 30 to 40 milliosmol per kg. Okay. Maximum osmotic gradient. I told you the corticomedullary osmotic gradient is there, and if it is 300 at the level of cortex, it will go towards the inner medulla, and here it will be 1200 to 1400 milliosmol per liter. So it is the inner medulla. B is the correct answer here, right? Then the primary driving force. I told you, whenever you want to generate the medullary hypertonicity, the first thing, the primary thing, that is reabsorption of sodium and chloride from which segment? TAL, thick ascending limb of loop of Henle. Sodium reabsorption. So this thick ascending limb of loop of Henle is the main segment, and this is the primary driving force. Sodium reabsorption. Obviously, if the sodium is reabsorbed, that transporter is dedicated for chloride reabsorption also. So this way, this is the correct answer. Which of the following is not a component of counter current multiplier mechanism? Look at the question. It is the multiplier question. It is not the exchanger. So the vasa recta is part of the counter current exchanger. It is not part of the counter current multiplier, right? So that way, vasa recta is the answer. And if I ask you, which of the following segment has least important role is counter current system? Your answer will be ATS, ascending thin segment of the loop of Henle. Okay, I told you the loop of Henle TL is very, very important. Medullary collecting duct is also very, very important. ATS is the least important segment for counter current multiplier system. So this is all about your counter current system.